So next we will go to diagnosing and managing ischemic optic neuropathies. Dr. Kiran will be presenting on this topic. He's a VR consultant from Comtrust Hospital.
Good afternoon. I'll straight away start with the case. It's a 56-year-old male, known case of coronary artery disease and hypertension, came with complaints of blurring on right eye on waking up with 6/60 vision and RAPD. This shows sectoral hyperemic disc edema, and FFA done shows sectoral filling defect. And HFA was done, which showed an inferior altitudinal field defect. VVP done showed right a decreased amplitude and mild prolongation of the latency. This is a typical non-arteritic non-arteritic anti-ischemic optic neuropathy. Ischemic optic neuropathy can be classified anatomically into anterior and posterior. Etiology-wise, they can be classified into arteritic and non-arteritic. The blood supply of the optic nerve, it's already discussed, I think, short posterior ciliary artery, and they have watershed zones in its circulation and have segmental supply. That's why they have altitudinal field defect. Non-arteritic AON is the most common acute optic neuropathy in patients over the age of 50. The pathophysiology, the main pathophysiology is hypoperfusion, though rarely occlusion to an emboli can occur. The major risk factor is a crowded desk, optic disc drusen, angle closure glaucoma, marked optic disc edema, and also the location of the watershed zones of the posterior ciliary arteries in relation to the optic disc. Coming to the systemic risk factors, the nocturnal arterial hypertension is considered one of the major risk factors. That's why the patient develops blurring on waking up. Aggressive hypertension can again worsen the nocturnal arterial hypertension. Other systemic risk factors include ischemic heart disease, hyperlipidemia, sleep apnea, malignant arterial hypertension, migraine, aggressive hypertension treatment. Other medications such as sildenafil and amiodarone have been attributed to non-arteritic AON. Usually the vision stabilizes by 1 to 2 months. So any progression after 2 months should raise suspicion. We should think of alternate diagnosis. Lifetime risk involvement of the fellow eye is 30 to 40%, and more importantly, spontaneous visual improvement can be noted in around 40% of the patients. So the treatment is basically focused on controlling the risk factors. So we should avoid nighttime antihypertensives, treat the coexisting diseases, and check for any offending drug. Steroid has been studied in NAION, and some studies have shown improvement up to 70% in treatment group and 37% in untreated group. But many studies have not failed to produce consistent results. Many other treatment has also been tried, like intravitreal anti-VEGF, intravitreal optic nerve decompression, aspirin, but none of these studies have provided consistent results. Coming to the next case, this is a 72-year-old female with history of transient blurring of vision, RAPD, BCV of counting finger vision. She gives history of headache and jaw claudication. A disc shows pale disc edema with ciliary artery occlusion, and FFA shows a large area of choroidal filling defect suggestive of short posterior ciliary artery occlusion. Workup showed markedly raised ESR and CRP, and temporal artery biopsy showed features of granulomatous inflammation, and an arteritic AON was diagnosed in this patient. This is another patient who came with vision loss to PL in the month's time, left eye followed by the right eye, and both eyes showed features of central artery occlusion. On FFA, it showed features of CRAO along with an area of choroidal filling defect suggestive of posterior ciliary artery occlusion, and workup showed GCA. So I just want to highlight that GCA can produce blurring of vision in the fellow eye in a matter of few days. So we have to start the treatment aggressively to prevent blindness. In arteritic AON, giant cell artery is the most common cause. So other rarer causes are vasculitis such as SLE. It's more commonly in elderly, and marked visual loss and amaurosis fugax is another presenting feature. The most common systemic feature of GC is headache, but the most specific one is jaw claudication. Other features are tenderness of the temporal arteries and the scalp. So one thing to remember is in 20% of arteritic AON, they can present with visual problems alone without any systemic features. The ESR and CRP remains the main investigation. Together, they can produce a specificity of say, 97%, but in 10% of the patient, the ES and CRP can be normal. Temporal artery biopsy is the mainstay of, gold standard for diagnosis. But we have to remember about the skip lesion. So, 2.5 centimeter of artery should be collected to study it. The non-invasive investigations include color Doppler, duplex ultrasonography, and MRI, which can localize the edema and the focal stenosis. It should, arthritic AN secondary to GCA should be considered a medical emergency due to the affection of the fellow eye, and also it carries life-threatening complications such as stroke, aortic dissection, myocardial infarction. So steroids should be started immediately and shouldn't be waited for the results of the temporal artery biopsy. We should start treating with intravenous medial prednisolone, and it should be titrated based on the ESR and CRP. And majority of the patients require lifelong steroid treatment. So they should be started on, some patients may need steroid sparing agents such as methotrexate, and tocilizumab is a monoclonal antibody approved for the treatment of GCA. Coming to the posterior ischemic optic neuropathy, in this case, the patient usually don't present with the disc edema. They usually present in 3 settings. One is the patient who have undergone prolonged surgeries such as spinal surgeries or radical neck dissection. It can occur as a very uncommon complication of GCA, and it can be associated with other vascular risk factors too. So they usually present with no disc edema. Usually the perioperative PAON, they usually present with painless bilateral marker blurring of vision with no evidence of any disc edema. So the only positive findings will be the blurring of the vision and afferent pupillary defect. So in such patients, we should consider PAON as a diagnosis of exclusion, and we should work up for other causes of bilateral blurring of vision, such as cerebral loss, cerebral causes of the blurring of vision. And to conclude, NAON, the main treatment is targeted on controlling the risk factors. Look for hypertension, sleep apnea, avoid nighttime antihypertensives. And in arthritic AON, it should be considered as a medical emergency. Once after diagnosis, should be started immediately on steroids and not to wait for the biopsy. And in PAON, it's a diagnosis of exclusion and should be suspected in all cases of prolonged surgeries and whenever we suspect a patient is having a GCA. Thank you.